Right, so where we're going with this is just starting with your nares, and we're just moving from top to bottom through the respiratory system. So we're starting out with the conducting zones, and then we're going to move into the respiratory zones. Okay, so the pharynx, the common opening that air passes into in food. So behind your nasal cavity, oral cavity, and around the larynx right there. Right, so the nasopharynx, behind the nasal cavity, but above your soft palate. Okay, just air passageway. Closes off during swallowing. Uvula flips up. Seals it off. Okay, you have pseudostratified ciliated columnar epithelium in the nasopharynx. Your entire nasal cavity, pretty much the same epithelial tissue. So to there, PSCC. Okay, there's a tonsil back there, pharyngeal tonsil, to get rid of bacteria. Okay, your oropharynx, behind the oral cavity. Here the epithelial tissue is going to switch to stratified squamous because of abrasion resistance. Because food's coming in your oral cavity. And it's going to stay stratified squamous in your laryngopharynx or laryngopharynx because there's going to be abrasion happening there too, because it's a common opening. And then food's going to go down your esophagus. Your esophagus is posterior to your trachea. It's behind it. As soon as we move into your larynx, and moving down the trachea, we're going to switch back to pseudostratified ciliated columnar epithelium. Okay, oropharynx, passageway for food and air. Stratified squamous ET. Yeah, you have some tonsils there. Tonsils. Just basically little pockets. That trap pathogens. Part of the lymphatic system, part of the immune system. Okay, laryngopharynx opens into the larynx and esophagus. Okay. Food and air moves through there. Stratified squamous epithelium. All right, so let's check out this larynx. So what the larynx is it's a hyaline cartilage structure that's at the top of your trachea. So it's a hyaline cartilage structure at the top of your trachea. The larynx contains an opening known as the glottis. So your larynx. It has different parts, this larynx. And we'll look at the parts. Or shall we say components? Okay, the larynx contains the glottis. What is the glottis? So basically, you could think of it as the opening to the trachea. So the glottis can be closed or open. The borders of the glottis are your vocal folds. Your vocal cords. So air moving through the glottis gives rise to sound production. So here's what the larynx looks like. And there's this big kind of like a hyaline cartilage tongue structure, tongue-like structure called the epiglottis. That's this right here. The epiglottis is elastic cartilage. Okay. So the larynx, the cartilaginous structure that surrounds and protects the glottis. Glottis, narrow opening in the larynx where air from the pharynx moves to the trachea. You could kind of think of it as the entryway to the trachea, the opening. We're looking down straight from above, looking down into your larynx, you would see the glottis, and this is the glottis right here. So it's kind of a V-like opening. It opens up like this to let air into your trachea.
So the glottis is the V-like opening, or it's that like tissue that the red is pointing at?
It's the whole structure.
Okay, cool.
Yeah. Yeah, this whole structure, I'll just call this the glottis. Okay. The epiglottis is up above it. So here you're looking at the larynx, and you can see the glottis. So the glottis, basically the borders of the opening are your vocal folds, your vocal cords. You see them right here. And technically, there's this rhimaglottitis or rhimaglottitis is the actual opening in the glottis. Whatever. So here we go, glottis, vocal folds, and the rhimaglottitis, the opening right there. Okay, 3 functions, that's for the larynx. Okay, open airway, air and food goes in the proper channels, voice production. And what does this mean? We look at the larynx overall, there's the epiglottis. Okay, so this epiglottis is above the glottis. Basically, if you put your hands right here on your throat and then swallow, you'll observe something happening. Do you feel a structure moving up when you swallow? You feel something moving up? Okay. That's your larynx. It's moving up. When it does that, moves up, it tips the epiglottis down, and the epiglottis seals off your glottis. So when you swallow, your larynx moves up, which tips this epiglottis down. And it's going to seal off your glottis so you don't end up with food in your windpipe. So that's why the larynx can it seals off your windpipe, routes food into the proper channels. Okay, the larynx, we're looking at the larynx right here. Okay, there's a bunch of ligaments, membranes, things like that anchor it to the hyoid bone. When you swallow, those suprahyoid muscles contract, elevate the hyoid bone, and take the larynx with it, which tips the epiglottis closed. So that's why if you put your hand on your throat and swallow, you can feel it. Okay, so the larynx has a bunch of hyaline cartilage instead of bone. Okay. The exception is the epiglottis is elastic cartilage. Inferior to the larynx is your trachea. Okay, the trachea is ringed with hyaline cartilage to keep it open. But these rings don't form a complete ring. See in the posterior aspect of the trachea, the back of it, do you notice there's no cartilage right there? See that right here? There's no cartilage. That's because your esophagus is sitting right up against it. The esophagus needs room to expand. When you're swallowing a watermelon, a whole watermelon, like a snake, your esophagus expands forward. So that's why this back region's open like that. Okay, so let's look at the different parts of the larynx. We have different cartilage here. Okay, we have the thyroid cartilages, which is the big top uppermost part of the larynx. This is thyroid cartilage right here. You can see in the back, the thyroid cartilage is open. So thyroid cartilage. Below it is the cricoid cartilage. The cricoid cartilage, it's like a signet ring, a big thick ring with your official seal on it. Back in the old days, the king or whatever, queen, they'd have the front, there'd be a big ring that had the royal symbol, and they'd stick it in wax and then seal a letter, or seal a letter with wax and stamp the ring on it so you know it's from them. So it's like a ring like this. That's a side view of the ring. That's the cricoid cartilage. So this is posterior, anterior. So we have the front and the back. Here's the cricoid cartilage. You see the thin part of the ring, and then on the back, it's the thick signet, the seal that you're going to stamp in the wax. So the cricoid cartilage is below the thyroid cartilage. And then we have a couple other little pieces of cartilage. The most important are the arytenoid cartilages. This is cartilage down here, arytenoid cartilage. The arytenoid cartilage, that's what the vocal cords are attached to, or the vocal folds. There's some muscles back here, and let's not worry about their names. We'll call them Bob, Frank, and Ted. Some muscles contract, and when they do that, okay, that opens up the glottis. That pulls on the vocal cords, the vocal folds. So the arytenoid cartilage. And then there's these little horns on top called the corniculate cartilage. Yeah, and there's some cartilage on the side called the cuneiform cartilage. Anyway, the arytenoid cartilage, that's basically what the vocal cords are attached to. So let's look at all this real quick. Awful. Okay, so here we have the larynx, the different parts, right? This is your glottis, basically. Okay, mucosa of the larynx, whatever. Right. So here we go down. This is the rheumatoid, the opening. Jesus, so sorry about that. It's touchy. Okay, here's the rheumatoid. This is basically your glottis right there. Right there. Let's undo that. I'll just get rid of it. Okay, here we go. Here's your vocal folds. Okay, vocal ligament. Okay, and that's opening into the glottis. Okay, here's your epiglottis. Okay, that flap, when you swallow, this seals off your glottis. Here's the thyroid cartilage. And what's the cartilage below the thyroid cartilage? The signet ring. What's the cartilage that's below the thyroid cartilage?
The cricoid.
Yeah, there we go. Okay. Okay. Here's the arytenoid cartilage. The arytenoid cartilage. Let's get rid of this. Okay. Here's the arytenoid cartilage. Okay. And the arytenoid cartilage is attached to your vocal folds. And the corniculate cartilage is the little horn right there. That's the corniculate cartilage. Okay. Arytenoid cartilage, corniculate cartilage, thyroid cartilage, cricoid cartilage. Don't worry about the cuneiform cartilage. It's on your list, but we're just going to ignore it. It's not important. So these are the four main cartilages. Okay. So your true vocal cords, these basically are on the borders of the opening of the glottis, the rheumatoid. Okay. The arytenoid cartilage, there's muscles back here that pull on the arytenoid cartilages, which open up your glottis. When air rushes over these vocal folds, sound is generated. There's also the vestibular folds that are above the true vocal folds. They're called your false vocal cords, the fakers. These are the true vocal cords directly below. They frame the opening of the glottis. Okay. The false vocal cords just modify sound production a little bit. And the epiglottis slams shut and seals the whole structure off. There. Now we have the larynx isolated. Okay, let's label the larynx. Can anyone tell me what that is? Little guy right there.
A cuneiform cartilage?
Now you're gonna remove that from your list.
Oh,
That's
okay.
the form cartilages right there.
Is it the corniculate cartilage?
Yes, it is. You're spot on. Corniculate cartilage. Okay. What cartilage is this?
The arytenoid cartilage?
Arytenoid cartilage. Okay, this one?
The cricoid cartilage?
Yep. And this one?
And the thyroid?
Yeah. Now there's a region right here, a raised region. In a male, you can see it's quite prominent. It's called the Adam's apple. It's because of androgens, male hormones makes that more developed than in a female. That's called the laryngeal prominence. It's on the front of the thyroid cartilage, Adam's apple. Okay. Finally, what is this structure called?
The epiglottis.
That's it, epiglottis. Now, what kind of cartilage is the arytenoid cartilage made out of?
Hyaline.
Yep. What kind of cartilage is the arytenoid cartilage made out of? Let's cut to the chase. All the cartilage here is hyaline cartilage, except for the epiglottis. The epiglottis is what cartilage?
Elastic?
Yes, it's the only elastic cartilage besides your ears. That's it. Okay, you just labeled the larynx. Awesome. Let's check something else out. Okay, so this, you just have to start getting rid of a bunch of structures. Anyway, you can go in here and it's got all the same things. So here's the laryngeal prominence right there. Okay, thyroid cartilage. Okay. Okay, and we're in. Let's get rid of that too. So we're gonna have the cricoid cartilage, all our favorite cartilages. Arytenoid cartilage is right there. We can get rid of some more structures. Okay, we have our arytenoid, corniculate, everything's there. Okay, your true vocal cords, true vocal cord folds. Okay. Okay, there's our epiglottis. So everything's here, all the same structures. So what do you want to take away from this? All this level of detail right here. Your vocal folds can be closed or open. And the vocal folds are your true vocal folds. And then you have the vestibular folds are above them, the fake vocal folds. You can see vestibular fold right there. And here's your true vocal folds. Okay.
Professor, there's a typo on the previous slide though. Both of them say, I don't know if it's a typo. Are they both intrinsic?
What?
Just make sure that's correct. For the vocal ligament and the vestibular ligament, are they both intrinsic? I just was.
Just ignore that.
Okay.
It's intrinsic. No, there's no typo. It's irrelevant.
Okay.
Irrelevant. Yeah. Okay, so your trachea heads on through the mediastinum, right? So the trachea is basically just your windpipe. The trachea is going to split, divide into your left and right main bronchus. So your trachea is ringed with hyaline cartilage, C rings to keep it open. You don't have a complete ring because the esophagus is behind the trachea. Okay, there's the carina. I don't care about the carina. So here we go. Trachea down. Okay, trachea. The carina just refers to right there. Who cares? Okay, so we have a left and a right main bronchus. And that's it. Let's not worry about the histology of the trachea. All right, so you can see what's going on here. The larynx up at the top, and then the trachea. C rings. So if you look at a transverse section right here, you can see how the C rings don't go all the way to the back because your esophagus is back there. And if your esophagus expands, it's going to press into the trachea some. Okay, so let's look at the divisions of the conducting zone. So you have your bronchial tree, extensively branching respiratory passageways. Okay. The main bronchi, okay. Right and left, main bronchi. Then we go into lobar bronchi, 1 per lung lobe, 3 on the right, 2 on the left. We go into segmental bronchi. They branch off of the lobar bronchi. Then bronchioles, little bronchi. Terminal bronchioles, even smaller. Then we're going to go into respiratory bronchioles, alveolar ducts, alveolar sacs, and finally alveoli. So we're going to have a change in cartilage as we move through the respiratory passageways. On your trachea, we have C rings. Okay. When we move into the primary bronchi, we could have complete rings, and the rings are going to give way to plates. This is all hyaline cartilage. So you're going to see that you have C rings down the trachea and then complete rings around your main bronchi. And then that's going to give way to cartilage plates. Those plates are going to end, the cartilage ends when we reach bronchioles. It's going to be smooth muscle that's responsible for holding the airways open or closing them. There's also a lot of elastic fibers that are present in the bronchial tree. You're going to have a lot of elastic fibers, and elastic fibers increase too. Okay. So as we move down into terminal bronchioles, respiratory bronchioles, you will see these green structures right there. Those are elastic fibers. Okay. And all this pink that's being shown, that's smooth muscle. So the autonomic nervous system regulates how open or closed your airways are at the level of bronchioles. So this is basically, you have the bronchial tree, extensively branching respiratory passageways. And here you're looking at the bronchial tree. So we go trachea, left and right, main bronchi. We have 3 right lobar bronchi and 2 left lobar bronchi. Then we go into segmental bronchi, and we go into bronchioles. Here's just labeled smaller bronchi. Okay, the smaller bronchi, that's bronchioles. Into terminal bronchioles, respiratory bronchiole, alveolar ducts, alveolar sac, and alveoli. So what the alveolar ducts are like, it's like a nice hotel and you're walking down the hallway and there's doors all off to the sides to the rooms. Okay. The alveolar ducts have all the alveoli are opening up off of them. So here's an alveolar duct. The alveolar ducts, and you see one here. Basically, the alveoli are opening up off of the ducts. So it's that hotel hallway you're walking down with the rooms off to the sides, but there's no doors on any of the rooms. All the rooms have no door. So the rooms for the hotel coming off the hallway, all those rooms are the alveoli. I don't care about what kind of epithelial tissue's there. Who cares? All right, so your bronchial tree. Main bronchi, lobar bronchi, segmental bronchi, bronchioles, terminal bronchioles. What comes next after terminal bronchioles? What's after terminal bronchioles?
Respiratory bronchioles.
Yes. And what comes after respiratory bronchioles?
Alveolar ducts.
Yes. Which branch off, the alveoli open off with alveolar ducts. As soon as we reach respiratory bronchioles, we're in the respiratory zone. Some gas exchange can happen. Do you have any hyaline cartilage on bronchioles? No. It's all what? Smooth muscle and elastic fibers. Okay. So we have cartilage, 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 down to tertiary bronchi, segmental bronchi, and then we're done with the cartilage. Okay. Let's see. You have 3 lobar bronchi in your right lung and 2 in your left lung. The left lung only has 2 lobes. The right lung has 3. So for your main bronchi, the right one is wide and short. The left bronchus, left main bronchus, is long and narrower. Why? And here's another thing. Okay, so we're facing the individual. They're in standard AP. So the right bronchus goes down steep and it's short and it's big. The left bronchus is longer and not angled so steeply down. So this is left and this is right. Why is the left one like this?
Does it have to go?
Hi?
Go, Lucas.
Oh, is it because it has to go around the heart?
Yeah, it has to go. Yeah, the heart's right there. That's it. So if you were at the golf, I don't know, golf course, and you like to run around and snort golf balls like a big anteater, and you could do this, where's the golf ball more likely to get lodged? Is it going to fall into your right bronchus or travel down the left one?
Right.
Yeah, 9 times out of 10, if you were to snort a golf ball through your nostrils and get it down in and in, down and in, it would be there. All right. Well, heck, let's look at what's going on here. So here we have our alveolar ducts. We have alveoli opening up off the ducts. And then there's alveoli out here and so forth. So one of them is an alveolus, but when we're talking about all of them at once, it's alveoli. Right, so this is where gas exchange is actually occurring. So these sacs that open off of the alveolar ducts, the alveoli, they are connected to one another by alveolar pores. This way, when air moves down and in, it moves through the pores to all the different alveoli. Suppose you have an alveolar duct obstructed or your airways are obstructed. This way air can get into all your various alveoli more than one route. So air fills up the alveoli simultaneously, and if you have obstructed airways, some of them, air is still going to find its way into your alveoli. Now, wrapped around the outside of these alveoli, you have pulmonary capillary beds. So we have deoxygenated blood flowing into these capillary beds, and it's getting oxygenated. So basically, each alveolus is wrapped with pulmonary capillaries. It's wrapped like a fishnet stocking. Now the alveoli, while they are little sacs, they're kind of clustered into different segments where an alveolar duct is running through them. They're grouped into whole groupings of little alveoli called an alveolar sac. So we have a whole bunch of alveoli. And here's another cluster of alveoli. It's kind of like clusters of grapes. So here's the alveolar duct coming in. So this whole grouping is an alveolar sac. And here's another alveolar sac. So like clusters of grapes. All right, so you have pulmonary capillary bed. There's also elastic around your alveoli too. So we could color that in yellow. Although I usually use that for nerves. Okay, you have like a net of elastic as well. Okay, so this is where gas exchange is happening. Well, you have two kinds of cells in the alveoli. This is the respiratory epithelium. Now we do care about epithelial tissue. On these slides, there's a bunch of too much information about epithelial tissue and histology of the trachea. All very interesting, but not during summertime. Okay. First of all, can anyone tell me what kind of epithelial tissue you would find in your alveoli?
Squamous.
What kind of squamous?
Simple.
Yeah. Simple squamous. Okay, but really we have two kinds of cells here. But we have type 1 . We have type 1 and type 2. Okay, type 1 are squamous. Okay. Gas exchange. Okay, they're there for diffusion. Most of the cells in this simple squamous epithelium, that is your respiratory epithelium, most of the cells that are present in your alveoli are there for gas exchange. However, there are a few type 2 alveolar cells that are scattered in your respiratory epithelium. They are cuboidal. There are a few cuboidal cells there. The type 2 alveolar cells produce something called surfactant. What is surfactant? Surfactant reduces the surface tension of a liquid. So water has high surface tension. Water molecules stick together really good, very well, because of their hydrogen bonding. So they hold together. What a surfactant does is it makes that surface tension weak. So water usually, actually, you wouldn't think so, but it's difficult to break the surface of water. Have you ever seen a water strider, an insect that's walking on water? Water has high surface tension. It likes itself more than it does the air. Well, a surfactant breaks that. Here's the thing. Your alveoli, there is fluid in there. They are so thin and so delicate that the fluid inside your alveoli, the aqueous environment, the water, would make them collapse. They would collapse and you couldn't get any air in and you'd be dead. So these type 2 alveolar cells produce a surfactant that coats the inside of the alveoli so that they cannot collapse.
In NICU babies, there's type 1 and type 2 respiratory distress syndrome, and it has to do with these, which now it all makes sense, a lot more sense now.
Cool. What are these?
In NICU babies, like neonatal, when like newborn babies go into the NICU, the intensive care unit, there's two types of respiratory distress syndrome for them, type 1 and type 2. And typically, now it makes a lot more sense because of the type 1 and type 2 alveolar cells. And I remember talking to a doctor about it, and he was explaining the difference, and now the difference makes a lot more sense.
Oh, so they could actually have type 1 alveolar cells or non-functional?
Yeah, so like what he was explaining to me was like the type 2 has more to do with like the surfactant levels within them, and then the type 1 has more to do with the the alveoli and stuff like that.
The diffusion. Okay.
So
Weird.
this makes a lot more sense now that I've learned this.
Cool. Okay, so here's the two kinds, type 1 and type 2. So type 1, squamous, diffusion. Type 2, the surfactant. So there's a few cuboidal cells. So here you see them right there. Okay. All right. So here you see alveolar pores. So there's these holes. That's an alveolar pore. That's one. So if different passageways are blocked off, respiratory passageways, the air can still get to individual alveoli. You also have alveolar pores because there are alveolar macrophages in there. These are immune cells, white blood cells, and they're hanging out in your alveoli to deal with any pathogens or particulates that get in there. Any debris, they're there to clean it up. And they move through pores from one alveolus to the next. So the pores are there to keep your alveoli inflated, and they're also there for that alveolar macrophages to move around. Alveolar macrophage is a white blood cell. Okay, so what's your respiratory membrane? Basically, you have a squamous cell. So here's a type 1 alveolar cell with a basal lamina that all epithelial tissues produce. That's just the acellular extracellular matrix, the actual glue that epithelial cells sit on. Rather than having connective tissue below it, so we have a full-on basement membrane, on the other side, we have the simple squamous epithelial tissue that is the tunica intima of a capillary. So we have squamous cell, type 1 alveolar, basal lamina, and then a capillary endothelial cell. Endothelium, it's an epithelium. It's just called endothelium because it's inside. So we have a squamous cell, basal lamina, and a squamous cell. That is the tunica intima. Recall capillaries are just a tunica intima, that's it. So erythrocytes move through these pulmonary capillaries. You are here. That's where you are, where the star is. You are here. Air move down and it's in your alveoli. And then the oxygen just diffuses right into your red blood cells. So O2 in and CO2 out. There it is. So that's your respiratory membrane. So this is the fine level of detail. Now if we look over at the left, you can see alveolar duct right here and how we have openings in the alveoli, and a whole grouping of alveoli like a cluster of grapes is an alveolar sac. And the alveoli are wrapped with elastic fibers and pulmonary capillaries. So guess what's moving down in blue into the pulmonary capillary bed? A pulmonary arteriole. Pulmonary arteriole into the pulmonary capillaries, bringing deoxygenated blood to get filled with oxygen. And then what is this red structure, this red vessel that's coming off of the capillary bed? The pulmonary capillary. I'll give you a hint. Its first name is pulmonary. What's its second name? What's the second word for its name? What's its last name? We have pulmonary arteriole and the pulmonary capillaries that converge into the pulmonary what?
Venule?
Boom, there it is. Pulmonary venule. All right, which are going to converge into pulmonary veins eventually. So there you have it. Isn't that awesome? Okay. Now, visible body has a model of this. There is a typo. And I have let them know of this. Maybe they fixed it by now, but I doubt it. They have the pulmonary arteriole listed as a pulmonary artery. That is sloppy. It's a pulmonary arteriole. And then we have a pulmonary venule. Visible body will tell you pulmonary vein. Don't believe it. Okay. As awesome as that fleshy colored larynx was, it's not that awesome. Let's look at this. All right. So here you go. Okay, so this is the smooth muscle that's around these fine bronchioles and all that. So this right here is an alveolar duct, okay, running down, and then we have all the alveoli. This whole cluster right here is an alveolar sac. We see little fine elastic fibers around the alveoli. There's also elastic fibers on this. I would guess that this is an alveolar duct right here. So these are terminal bronchioles, and then we're running up into a bronchiole. I'm sorry, respiratory bronchioles, terminal bronchiole. Whatever, don't worry about that so much at the end on this model. Okay, this right here, that is a pulmonary arteriole. And then what's coming off are pulmonary venules. Notice the venules are oxygenated red. and the arterioles are blue, deoxygenated. Here you see the pulmonary capillary bed, capillary network, and then there's elastic. Really, both are present. You can see a capillary network and elastic net around each alveolus. So it's not a whole lot going here on this. It's not bad. We just have smooth muscle, okay? This is an alveolar duct, which is coming off of, so those are all alveolar duct, then this must be respiratory bronchiole, and it is. And then this would be a terminal bronchiole. So terminal bronchiole, respiratory bronchiole, alveolar ducts. We'd have alveolar pores. Okay. As far as the cells go, we're never going to get to look at those. Let's check this out and see if they fixed the typo.
Professor, I have a question.
Yeah.
Is the alveolar duct the alveolar sac, or are they completely different? Because in the picture,
100% different.
okay, because
Yeah.
in the picture it says like it looks like they're together, or like in complete anatomy it shows like it was highlighted everything.
I know, it was tagging it together.
Okay, but the duct is like the little.
It's the end. Yeah, it's the final branching.
Okay.
The duct is the hallway in the hotel.
Mm-hmm.
The rooms coming off of it, which are the alveoli.
Okay, got it. Thank you.
What am I doing here? Let's see if they fix this. Pulmonary capillary beds. There's no elastic shown here at all. So to see those elastic baskets, you're gonna have to be looking at the slideshow in the textbook because they have it. Okay, so this is smooth muscle, bronchial or smooth muscle. What's that? Alveolar duct, respiratory bronchiole, terminal bronchiole. Okay, all the way to the end. Okay. Pulmonary vein, it's still screwed up. They didn't fix anything. It's a pulmonary venule, and this is a pulmonary arteriole. Right. So there's no elastic shown here or anything. But you know there's elastic around the alveoli, and there's elastic around these bronchioles too. There's elastic everywhere. Out of that courseware. Okay, so your lungs. You have an apex, which is there. That's the pointed top. And you have the base. Rounded end sits on the diaphragm. Which cavities do the lungs reside in? Specific cavities that are located within the thoracic cavity. There's two of them.
Visceral pleura and parietal pleura?
Yes, are inside of the pleural cavities. So you have the pleural cavity and you have the parietal and visceral pleura. So the parietal pleura is lined inside the thoracic cavity. It sticks to the inside thoracic cavity walls. The visceral pleura is fused on the outside of the lungs. What's in between the two pleura?
Mediastinum? Is that how you say it?
No.
Or for the heart?
I see what you're saying. Between the pleural cavities.
Oh, I see.
Sinum. For sure, you're correct on that. I'm talking about what's in between the actual serous membranes.
Is it serous fluid?
Yes, name that fluid though. It has a name. The what fluid? It's between the parietal pleura and the visceral pleura. What would you want to call it? How about the pleural fluid? That's it. Okay, so the pleurae are stuck together because of that fluid like two panes of glass. Have you ever seen glass and there's water between it? Maybe you have, maybe you haven't. If you try and pull that apart, you can't. It sucks. You can slide it around, one pane of glass on the other, but if you try and physically pull it, it's stuck together. So that's what the pleurae are stuck together like that. So the parietal is on the inside of the thoracic cavity, the visceral on the lungs. So when your thoracic cavity expands out, the parietal pleura is going with it, and the visceral pleura is pulled along for the ride because they're stuck together with the pleural fluid. So where I'm going with that is ventilating your lungs has to do with muscle contraction, increasing the volume of your thoracic cavity. More about that in a second. Okay, do not try and memorize what ribs, where, and all this. So I don't care about all this on here. What we want to get to with this is that the right lung is larger and has 3 lobes, the left lung's smaller. There's also the cardiac notch right there. What's up with the cardiac notch? Okay, your heart's right there. Okay, the pleurae. Okay. So you have friction-free movement of your lungs. You can get weird conditions where the pleural fluid's compromised and then you have problems. Okay, the lungs. You have something called the hilum. That's just sort of an opening where the main bronchi and the pulmonary veins and pulmonary arteries, they all just sort of feed into this hilum. Okay, hilum, groove where the bronchus, blood vessels, nerves access the lungs. So it's an opening. Okay, everything's going in there. Okay, you have fissures on the lungs. The lungs always have an oblique fissure. Both of them do. There it is, oblique fissure. Okay, the left lung has a superior lobe and an inferior lobe. There's only 2 lobes. The right lung has an extra lobe, or the left lung's missing one. So we have a superior lobe, an inferior lobe, and then we have a middle lobe in the right lung. And we have an extra fissure, the horizontal fissure. So both lungs have oblique fissures. The right lung has a horizontal fissure too, and a middle lobe. Both have superior and inferior lobes. The hilum is that groove opening where the respiratory tree, nerves, blood vessels are penetrating into the lungs. Okay. There's also the cardiac notch for the left lung, because that's where the heart's located. Okay, so blood supply. All right, we know that the pulmonary arteries and veins have to do with the pulmonary circuit. The point of that is to pick up oxygen. However, there's also the systemic circuit brings blood itself to the lung tissues because the lungs need blood, they need nutrients. So you have the bronchial arteries supply oxygenated blood and nutrients to the lung tissue itself. What's going to return deoxygenated blood back to the heart in the systemic circuit, the bronchial veins. So you have all that going on. So blood supply to the lungs, there's the pulmonary circuits bringing blood to the alveoli to pick up oxygen. The bronchial arteries are bringing blood to the lung tissue because it itself needs nutrients and oxygen. What's going on with all this? Too much. Okay. Right, so let's talk about how air actually moves into your lungs. Let's say pulmonary ventilation. Pulmonary ventilation. Okay. So we have your diaphragm. So at rest, you're not taking a breath in, you're not taking a breath out. That's situation one. So at rest. Your diaphragm is convex. It's concave up. The diaphragm is curved naturally when it's relaxed. And the base of your lungs are sitting on it. Well, in this case, the air outside of your lungs, let's suppose we're at sea level, it has a certain pressure, atmospheric air pressure, okay, at sea level. The air pressure inside your lungs is the same. So we have just regular air pressure, in and out's the same. Now let's suppose inhale. When you inhale, the diaphragm contracts, which means it gets flatter. Diaphragm contracts and it moves down. The parietal pleura is kind of stuck to the top of it, so when it moves, it brings the lungs down with it. At the same time, your external intercostals are contracting. When they do that, they pull your ribs up and out. So the diaphragm contracts, the external intercostals contract, and your thoracic cavity expands. Inhale. Diaphragm and external intercostals contract. So thoracic cavity expands. expansion of the thoracic cavity. The visceral pleura, the parietal pleura moves along with the thoracic cavity. It's stuck to the visceral with the fluid. The visceral pleura gets pulled along as well. So as the thoracic cavity volume expands, the volume inside your lungs expand. Well, you may remember, or you may not remember, or you may have never heard of it. The pressure of a gas is inversely proportional to its volume. That is the volume of a container that holds a gas in it. If a volume increases, then the pressure of the gas decreases. If the volume of a container decreases, the pressure of a gas increases. It's Boyle's law. For gases, pressure and volume are inversely related to one another. If one goes up, the other has to go down. So at rest, atmospheric pressure was 760 millimeters mercury. And don't remember that number. Outside, and it was the same. So it's out and in. The pressure is the same. In your lungs and out. You're not inhaling, you're not exhaling. Now, when you inhale, because the diaphragm and the external intercostals contracted, they just increased the thoracic cavity volume, which increased the volume of the lungs. So we still have 760 millimeters mercury air pressure outside. What do you think the pressure is like inside your lungs now that the volume increased? Up or down? For gas, pressure is indirectly proportional to volume.
So it increased as well.
The pressure inside the lungs?
Yeah.
No.
Decreases.
I just told you the volume went up because the diaphragm external intercostals contract. These arrows mean the volume in your lungs just increased. If this goes up, this goes down. It's like a fraction. Which is bigger? 1/4 or 1/20? Which is the larger number? 1/4. Would you rather have a quarter of a dollar or a 20th of a dollar? Well, you don't care either way because they say we're out of coins, supposedly. Okay, let's talk about $250,000, okay, dollars. That makes me happier. I'll take that. Okay, so you inhale. We end up with about 758. What happens is air moves into the lungs because the pressure is lower. Low pressure, the gas moves towards it. So that's how you take a breath in. Your thoracic cavity gets larger, the volume gets larger, the pressure in your lungs decreases, which means air rushes in. Just physics. That's how the air gets in. Now, exhale. Here's what happens. Your diaphragm relaxes, which means it goes back to convex, curved upward. Your external intercostals relax, which means your rib cage goes back to normal. So your thoracic cavity volume decreases, which decreases the volume of your lungs. Now, the volume of your lungs, they expanded and filled with air, and then they get small again. What do you think is going to be true? Is air pressure going to be greater in your lungs or outside of your lungs? Okay, air pressure is always the same. The pressure inside your lungs, because the volume just decreased, that meant that the pressure increased. So what happens is air rushes out of your lungs. So that was exhalation. It's also called expiration. So
So-
this is, huh?
When your diaphragm's at rest, it's still kind of curved up, and when you exhale, it's curved up as well.
Yes, it goes back to the relaxed state. Yeah. The normal state of the diaphragm is to be curved up. When it contracts, it gets flat, which increases the volume of your thoracic cavity. Okay.